Good morning and welcome to Day 2 of the Texas System of Care Community Resource Coordination Group's Conference. My name is Julia Abreu and I'm the CRCG State Coordinator within the Office of Mental Health Coordination at the Health and Human Services Commission. As you all know, CRCGs are county-based interagency groups that work to help connect individuals and families with complex needs to community-based services and supports. Their members include public and private agencies, nonprofit organizations, family representatives, and other community stakeholders. CRCGs are also supported by a memorandum of understanding between 8 state agencies. Currently, there are 146 CRCGs covering 244 counties in Texas, most of which serve children and youth. I want to highlight the important role that CRCGs play in communities across the state and recognize the level of dedication, commitment, collaboration, and creativity that it takes to sustain such an impactful community-based initiative for over 30 years. CRCGs work hard to meet the needs of their most vulnerable populations, and they exemplify the values of their communities. Through dedication and hard work of their leaders and members, CRCGs ensure that their community members are connected to the resources and supports that they need. The work of local CRCGs is truly remarkable, and we want to let you all know that we see you and we appreciate you. At this time, I'd like to ask that CRCG leaders stand so that we may recognize and thank you for the important work you do in your communities throughout Texas. And now I have the privilege of introducing Dr. Rick Shepler, who is our keynote speaker for today. Dr. Shepler is the co-director of the Center for Innovative Practices located at Case Western Reserve University. In operation since 2000, the Center for Innovative Practices disseminates evidence-based and evidence-supported behavioral health practices for youth and their families, including multi-systemic therapy, intensive home-based treatment, Mobile Response Stabilization Services, integrated co-occurring treatment, trauma-informed care, and high-fidelity wraparound. In 2021, the Center for Innovative Practices was chosen as the Child and Adolescent Behavioral Health Center for Excellence, charged with providing training and technical assistance for the state's Ohio RISE and Family First initiatives. Dr. Shepler provides training and technical assistance on children's mental health at the local, state, and national levels. His key accomplishments include leading the development of Ohio's intensive home-based treatment model, co-developing the integrated co-occurring treatment model for youth with co-occurring mental health and substance use disorders, co-developing the national program and practice standards for intensive home-based treatment, and co-developing Ohio's Youth and Family Consensus Statement on Resiliency and Children's Mental Health. Let's give a warm welcome to Dr. Rick Shepler.
Thank you. Memo to myself, shorten your bio. Nobody wants to hear all of that, nor did I. So, hi, I'm Rick from Ohio. I'm going to tell you about MRSS today. I'm really going to tell you about our experience in implementing MRSS, Mobile Response Stabilization Services, in Ohio. We did a statewide grant through SAMHSA And we took about 4 years to try to implement as much as we could in some pilot areas. And I got a ton of lessons learned to share. And so I really want to get to that part, but first I'm going to talk to you a little bit about what is this thing called Mobile Response Stabilization Service. I do also have to let you know that I have compulsive joke disorder, and sometimes I just spontaneously divert into something that I find funny, and you might not. So if you don't mind, just kind of like, yeah, and then I'll go right back. All right. So what do we know? We know that, crisis services should be available to anyone, anytime, anywhere. All right. What I also know is that kids' crisis services always were in the shadow of adult crisis services in many states and continue to be so. I will speak about Ohio, but I also know the same is true in Texas in terms of that kind of overshadowing. So do we have true crisis response services for kids and their families? And is it accessible, and is it statewide? I think that's the challenge. I think it's a challenge for every single state. There's a couple states that do it well, and they're usually the smaller states. So how do you make it regional? How do you make it work for you? The other part of good response is a timely response. The other thing I know about mobile crisis, if you will, is that mobile crisis has a big triage phase to it. And folks call in, and somebody on the other line thinks about what's going on, tries to stabilize what's going on. If necessary, as decided by the person on the other side, they would do a mobile outreach. That's how we've always thought about mobile crisis. With this new service, Mobile Response Stabilization, they have a phrase they use, which is just go. So when the family calls in, the kid calls in, the school calls in, the triage is it an emergency that I need to call 911? Is it just information and referral, or just go, right? So that whole triage component is really shortened, and it's not about the professional making the decision, it's about the family making the decision. So it's very much a youth and family informed approach to mobile response services. And I think that's the main difference, right, in this service. The purpose of these services is to decrease use of emergency rooms, law enforcement, and any kind of related to juvenile justice system. We have a way of criminalizing mental health, and what we need to do is make mental health services, behavioral health services, available enough so that we can divert from other system, more intrusive involvement in a kid and a family's life. And this is from the folks at SAMHSA, and they talk about mental health services, mobile response, mobile crisis service should be considered to be like any other health emergency service. So when you're thinking about police, fire departments, any other emergency service, a public service, is made available and funded everywhere, right? And in general, the response time, some places it might be a little better than others. But why don't we do that for behavioral health and behavioral health for kids and families is the question. I think 988 is a great step forward, and I think monies were put out to grow crisis services across our different states. But what is our state plan in making sure that there's a crisis continuum and that there is that level of mobile response that families need to be successful, to keep kids in the least restrictive environment, to help them be more successful in school, for kids that are involved in child welfare, for kids that are co-occurring substance abuse and mental health, for kids that have co-occurring intellectual and developmental disabilities, right? If they have a behavioral health crisis, what is our response? Regardless of system, regardless of where they come from, what is our response? I would say that youth and family stability and safety is a community responsibility. I started, I work at a university now, but I started in the field and working in doing wraparound, doing intensive home-based treatment, doing some crisis work. And what I realized is that everybody wanted our program to put on their shoulders all of this risk and safety, right? Concerns in the community. And that was fine, but the reality is it takes really everybody working together to help families with very difficult issues to resolve, safety issues, risk issues, etc. And even if they're not helping in a response, are they helping in the funding? Are they helping in creating a crisis continuum that meets the needs of their kids that are in their system? If we're talking about kids with significant mental health needs, we're talking about kids that usually cross over systems. So my kid that I'm serving probably might have functional issues over here, in here. That's what we know. So how do we work together? How do we pull our resources, pull our thinking about planning and response? I will tell you, if you build it, they will come. When we started doing MRSS in Ohio statewide just last year, it's now a Medicaid billable service. We had a ton of calls from the school. And you never know who's going to pick up on it first. But the school saw value in it because they had lots of things that were going on. They didn't know what to do with, so they would call somebody for an emergency response. So it does cross over systems. We do need to work together and to find the response together. By the way, if I say something that I think is particularly powerful, I'll pause. And I think that was one of those moments. Thank you very much. I really do need to shorten my bio. I mean, that was torture for you, wasn't it? It was like, and then he did this, and then he did that, and who cares? I mean, literally. Okay, so what is a youth crisis continuum? I mean, who knew with a keynote you get humor? I mean, you weren't asking me for that, were you? All right, so traditionally we usually have crisis hotlines, right? And the crisis hotlines usually are built originally for adults, and then we said, oh, what about kids? So we included kids, and sometimes we train the adult crisis hotline folks on how to handle a kid crisis. Oh yeah, and kids have families, by the way, right? And those, the crisis might be happening at the home. And then we had, mobile crisis, right? And mobile crisis, when I just think about the term mobile crisis, it feels good, it's the right thing. The question is, was it really mobile? Okay? Anybody do mobile crisis here? And, I think the question for me in Ohio is, well, the statement is when we had mobile crisis, they were screening so many of the calls coming in and triaging and de-escalating, which is fine. but there was limited mobile response, okay? And so how do you make that? You shift the weighting of the response versus the triage and the phone de-escalation. Crisis respite beds are important, especially if we're going to continue to decrease the use of hospitals for every crisis that kids have. But you can also have acute psychiatric hospitalization. You know, in Ohio, we have intensive home-based treatment, which is a 3 to 6 month intensive program to try to keep kids out of placement. Do you have those kinds of programs also? So one take-home point is mobile response stabilization in and of itself is not a complete system of care for kids. It's a component. If you don't have those other complementary services and supports, all you will have is crisis and crisis response, and you'll not have enough of it. So what are the other complementary services and supports that you have? Well, wraparound's always a great one to have, right? Care coordination. You know, I think you guys have multisystemic therapy and pockets. What are those intensive services that can go in longer term, but not really long, like 3 to 6 months, and stabilize a family and divert the placement? You know, mobile response is meant to be, the way they're designing it, a 4 to 6 week service. You go in, crisis stabilize, create a safety plan, and then do some linkage, a little bit of skill building, and things like that. And I'll get into that here in a minute. But, you know, when we think about youth and families we serve with, generational trauma, generational mental illness, all right? We're not going to fix that in 4 weeks. So it's a component, it's a critical component, but you need other things to support it. When I did wraparound in Ohio, the other thing that I realized is that families, in general, never ask for one more treatment service. Oh, please, I want more treatment, right? And how many kids said, oh, Mom, yeah, that psychotherapy, that's something I'm really wanting more of. So really, it's about mentors, supports, pro-social activities that typical kids are doing, but our kids might struggle to participate in. That's what families are asking for, and if they just had some support in making that happen. And let's not forget about the effects of poverty on families. When basic needs are not met, functioning in the family, it affects the functioning in the family. So it all fits together, right? So it's not just you pick this MRSS thing and you've solved the problems. It's much bigger than that. And then there's residential treatment. That's all I'm going to say about residential treatment. All right, so what's the definition? I'm going to read this because otherwise I'll butcher it. Mobile Response Stabilization Service is a brief, rapid response, home and community-based crisis intervention model. It's available 24/7, 365. It provides mobile crisis de-escalation, stabilization, linkage services for youth and their families experiencing emergent behavioral health concerns. All right, so that's the national definition. And these are the organizing principles behind it. The first thing is you provide help where the problem is occurring. The second thing that it's a meet the urgency with urgency. If the family is urgently saying to you, things are not going well, we meet that urgency with urgency. And that's why they have this just go approach. You get the call, you're in your car. In Ohio, we wrote a rule that says you have to be there within 60 minutes. In Connecticut, in New Jersey, they have to be there in 20 minutes. Yeah, good luck with that. But think about it from a family standpoint. From a family standpoint, that feels reassuring. That's a safety net. From a workforce, right? And from a statewide-ness, what we found out in Ohio is, that's really hard to accomplish. And I don't know about you guys, but we're having a heck of a time with workforce. So you can have all the shiny new services you want, but without the people to staff it, it's really hard. And so you might have to do some adaptations to make it work for you in Texas. What are those adaptations? Well, the first thing I know is Ohio's big, but you guys are much bigger, right? So just the travel time and space, if you're going to make it statewide, right? So, do you put a telehealth component in it? Maybe, right? What's that do to the mobile response piece of it? So I think that regardless of how you think about this, the question for me is, can you develop something that's a little bit better than what you have now, a little bit more responsive? It includes youth and families in the response. It includes youth and families in defining the crisis rather than us defining the crisis. And it lasts more than that moment, right? It lasts more than the initial response and good luck, okay? I'm going to come back tomorrow, and I'm going to call the next day. And we're going to do some safety planning today, and we're going to make sure that there's some basic safety in the home. We'll do some means reduction. What's that mean? I'll make sure oh God, I'm going to say this out loud, that the family is safe because of, weapons in the home are put away, or medication is locked up if it's necessary because you have a kid who might be suicidal. So what does it take to keep that kid safe in that home or wherever that child goes? Safety planning. I think that there's a consistency also in a statewide MRSS component. Many of the states that are implementing this thing are implementing some sort of a data quality tracking system where you're tracking how long it takes to get to the family's home. You're tracking what happened with the intervention and those things. So they really want to create consistency with it. And really the most important thing to know is that MRSS is grounded in system of care principles. So if you're doing system of care initiatives, and you guys are, this has the same set of principles guiding the treatment, guiding the oversight, and everything related to working with youth and families. Just like any other service in system of care, we focus on services that are culturally responsive, services that try to prevent more restrictive placements, more in-depth intrusion into another system like juvenile justice, right? We try to keep kids in the home where they are at. It could be that you're trying to stabilize a foster placement. Those things are important, especially when we have kids going to how many different foster placements before they catch on to one that might work, or, oh no, they're going to a group home, or, what if we had a service that also stabilized kids in child welfare? And as I said earlier, we are trying to divert from, emergency departments and things like that. And certainly decrease law enforcement involvement, because usually law enforcement has two options. Well, three. Lecture the kid in the back of their car, take them to the emergency room, or take them to a detention center. Well, maybe four options. Or they could even arrest an adult. It's not a behavioral health response to a behavioral health concern, right? So if we're using the wrong instrument to fix the issue, it doesn't, you get what you get. You get that other, law enforcement response. So how do we grow that behavioral health response in our communities? The other thing that we do in mobile response stabilization, which is different than some of the crisis hotlines or the very time-limited mobile crisis response, is that we have a little bit more time to build a few new skills with the family. So if there was intense family conflict, and that family conflict led to the youth throwing things, and there was things that were breaking, and somebody got hit by one of the things that got thrown, how do we go in, unpack that, and help the family do something different next time? Okay? So it could be that, for me, if we leave the family with one new skill, if we leave the child with one different way of communicating their needs, if we leave the family just a little bit safer, and if we leave and the next crisis is just a little bit less intense, we did a good job. You only got, even though you're extended in terms of what typical crisis services are, you still only have about, a month or so to make things work. So don't start something you can't finish. It's not therapy, but it could be one new skill for this family that's critical to them doing better. So here's the main components. There is a triage component. It could be your 988 in Texas. It could be linked to your local crisis response hotline. But there is an initial number to call, however you define it. In Ohio, we rolled out 9888. We wanted to be special in Ohio, so we added an 8. It's now 9888. I'm just kidding. I stuttered. All right, so 988 for adults. We decided not to use the 988 number. I'm going to do that again. Okay. 988. For kids, because we found that the 988 system responds to your telephone, your cell phone. So if I moved to Austin and I called in with a crisis, you're going to get a 330 number, and they're going to call back to Ohio saying, I got a person in crisis, because they don't have a way of geolocating yet. So what we decided was it would be much better for youth and families, especially if we're going to respond within 60 minutes, is to use a separate call center that was able to identify where the call was coming from. Even if they didn't say where, obviously you can use the families and the youth telling you where they're at, but if they don't, you would still know that this is in the general area where they were, because they were using a different process for identification. So they use the call center. We use the call center. They use a call center in Connecticut. I don't know about New Jersey, and I don't know about Oklahoma. I know Oklahoma is doing a mobile response-like service. And they've done a decent job with it, too, through some of their system of care grants. And I also know that Nevada has a statewide MRSS system, just so you know some of the states that are doing this already. And they're all doing it different. And they're calling it something different. So it's a little bit crazy making. But, so triage, we call into a call center. That call center immediately calls the mobile response team in that area and says, I'm going, and stays on the line and links the family to the MRSS response. And at that point, the call center's done. They've done their thing. They did a quick triage. Is this an emergency? Is this information and referral? Is this just let's go? Once it gets to mobile response, they're on their way. And they're linked with the family and initiating the kind of de-escalation that you would do with a family who might be in crisis. During the first session, it is very much standard mobile crisis. We're there, we're de-escalating what's going on. We're creating an initial safety plan with the family. We're coming up with a way of getting some agreement about follow-up. Not every family wants ongoing crisis intervention in their home. All right, so I might go out to one family and they say, thank you very much for stabilizing things. That's exactly what we needed. You're a nice guy, but we don't need you back. Okay, that's fine. But what we want to do, and we'll make sure we do in that first session, is say, we can be available to you for the next, whatever length your program is, 30 days, 45 days. We picked 42, 6 weeks in Ohio. Some states are 8 weeks, some are 4. But we want to make sure that you understand that our service can be available to you and your family if you would like that. And then you have a sales pitch. You have your elevator speech about, we'll be here to help work with you and your family and or the school just to, find some different techniques or strategies to keep things safe and stable for your family in that we can, but also link you to important services and supports in the community. So that happens in that very first day, maybe 2 days, because you're always doing follow-up and you're making sure the family's okay. We have about, I won't give a percentage because I'll butcher it, but about a third of our families only do the first 3 days. And a third do maybe a week or two, and then a third do the full amount. So it really is variable, by the way, because it's family defined. It's a family defined service. As I said, during the stabilization period, that third phase, that's when maybe the crisis has died down and we have an opportunity to unpack the escalation cycle of the family and the kiddo. And if it's at school, we unpack that as well and come up with a few different coping strategies, strategies for de-escalation, recognizing when things are getting hot in the family or with the kiddo. It's fine-tuning safety plans. So, what we've learned is that your first safety plan is not your last safety plan. You need to continue to refine it on what works and what doesn't work for that youth and family. And then the last part is linkage and transition. That's tricky. If you have care coordination, if you have wraparound in your area that you're serving, that should be your go-to, because then they will start to wrap around the kid. So some decision points for you guys would be, what's your access point? If you go this route, what is your access point? Is it going to be 988? Is it going to be a call center that you establish? regardless, you got to staff it, and regardless, you got to have people on staff that know how to work with youth and families. It can't be an adult-centric only call center or 988 center, right? At all points along the way, whoever touches the call or the family has to be able to assess risk and safety and do stabilization. The access point, will do your initial screen like, this is a 911 call. I need to get somebody out there. This is an emergency. The child's cutting on themselves. They currently have a sharp. They have a razor blade. They're not willing to let go of it, and there's blood, or whatever, right? Sorry. I saw faces, and I went too far. But then, the person receiving the call has to know when to just say, I'm sending somebody out right away. Stay on the line with me until they get there. So in Ohio, we have that emergency level. We have the immediate response level, just go. We also have a deferred mobile response. If the family says, I do want you to come out, but I don't get off my job until 5. Can you come out at 5:30? Okay? And since it's a 24/7 available service, and this gets to the staffing issue, that's fine, all right? We put some parameters around that if it's a deferred response. Number one, the family has to request it. I can't, as the professional, say, well, how about 6? Does that work for you? Okay? And in addition, we put a time frame. So within 8 hours or within 12 hours, you want to put in there, a deferred response happens within a day, basically, is the bottom line. So I think we said something like 8 to 24 hours. And we're tracking all of that because the thing that we know in mobile crisis is there can be easily drift where we're not going out as much. And it could be for all kinds of reasons, like staffing, et cetera, et cetera. And then information and referral. As I said during stage 2, you can see here, it includes the initial response, the initial crisis intervention, de-escalation, your initial safety plan, and then any kind of initial safety proofing of the home, right? Whether that's making sure there's locks on guns, that medication, if the kid is actively thinking about hurting themselves and they've used prescription meds before, right? So that typical stuff you would normally do, but that's what we want to do within that first 72 hours, create safety. Create safety. And as I had mentioned with the stabilization phase, it gets into all of those things around continuing risk reduction, unpacking the cycle for that youth and that family, the escalation cycle, doing some skill building, maybe teaching some behavior management strategies. We used to call that parenting skills, but Medicaid doesn't pay for parenting skills, they pay for behavior management. So I call it now behavior management. And then what other resources and support interventions can we put in place quickly? As I finish and I'm thinking about, this is quick too, so 4 to 6 weeks is going to happen like that. So you always have to be thinking about who's going to be next in this family's life to help them the very first day you go out. So who am I going to link them to? Who have they had good experiences with? And again, if I'm going to be consistent with the family's experience, how do I pick somebody who utilizes system of care principles? in the way that they deliver the service, right? Because otherwise it could be just a big shock to their system. So that's the service in general. I'm going to tell you a few things about lessons learned, which is much more interesting than the rest. There is no caseload size. There is no family load size, right? When you look at a service like multisystemic therapy or even wraparound, there are numbers of people that you serve at any given point in time. MST, 4 to 6 families. Wraparound depends on where you see it delivered, anywhere from 10 to 20, right? MRSS doesn't have a number. Do you know why that is? The reason why is that you always have to have capacity to do the emergency call response. And I might have scheduled an appointment, and I might have to reschedule the appointment. So I can't limit it. And if I'm in the field with 4 to 6 families now, serving them intensively during the week, I limit how much I can do my emergency response. So it's got to be a really flexibly delivered service. They don't talk about size of, the number of families they're serving. So I think that's really different. I will tell you that what I've learned about MRSS nationally is that they don't talk a lot about the stabilization phase, right? We had to really develop what the stabilization phase was. The other thing is they don't have like a fidelity measure nationally. We had to develop a fidelity measure for Ohio. What's a service supposed to look like? How well is that provider delivering it to that way the model was designed? I think the good news is that as long as it has certain principles in it, you can call it MRSS, and you can make it so that it works for your space in Texas, wherever that is, your community in Texas. We tried an approach where we put it in our Medicaid set of rules and our mental health set of rules, and in Ohio we have any willing provider. So anybody who wants to provide the service, as long as they meet certain certification requirements at the state level, they can provide the service. Well, that doesn't really help. So in one of our counties, we have now 4 mobile response stabilization providers. That's confusing, right? That's just darn right confusing. Because we created a rate to help fund this thing that was pretty darn significant. So everybody now wants to jump into the business of MRSS. Creating an organized response, though, might take, that has really worked counterproductively with an organized response. Who do we call when, who's available when, et cetera. We are now going a year and a half now into MRSS full implementation to a regional approach. I think it's the best way to go. I think there are problems with any way you look at it. We have 88 counties in Ohio. We were doing it in every county. We were trying to put it in every county. We didn't have it in every county. That was the problem. So if you're going to have something statewide, I think something regional might work, probably better. I don't know that any willing provider works. I think really for this, it might have to be like an RFP that you put out at a state level, something like that. The other reason we're going to regional is workforce. So we are struggling with workforce across all of our services, no different for MRSS. So regional, you can condense. And regional, you can make sure the services are available 24/7. We were struggling with 24/7 because we didn't have a workforce. So these are all implementation issues to think about, right, as you're designing something from the ground up. I think you should be intentional about how MRSS fits within your bigger system of care. What role is it supposed to take? My concern about MRSS is that when you have a 4 to 6 week stabilization and the family, loves who you are and what you're doing, and the provider loves helping that family, there's going to be, and we need to stay with this family 6 more weeks, and 6 more weeks, and 6 more weeks. The problem with that is you can't be available to new families. So how does it fit, and what's the handoff? The handoff is pretty critical. Wraparound makes a lot of sense. Care coordination makes a lot of sense because they can continue to fine-tune what that youth and family need to be successful. The 24/7 is a workforce issue. And the reality is, when I think about what we do and how we help, we don't pay you guys enough. Right? We just don't. We've been making this, everybody's making an issue, but with COVID and what happened with COVID, and everybody's doing now telehealth in private practice, and we can't find anybody that wants to work out in the home and community, let alone for something that costs, that, you make the same amount that will qualify your family for Medicaid. True? It's true in Ohio. Right? So you better have a bunch of Mother Teresas ready to go out and serve. Right? And I bet you we got a bunch of you guys right here. And that's a great thing. But, come on. We all have to live somewhere. We all have to pay a mortgage or rent or buy food, and right? Our basic needs shouldn't get in the way of our helping a family, the families we're serving with basic needs, right? So, are we paying enough? And can we find people to do those crazy hours, right? What's it take to want to work with, to travel to somewhere in the community that you're less familiar with, to stabilize a kid who might have a sharp in their hands? That takes a special person. So finding those folks, this is all about right now, post-COVID, it's about workforce development. It's about workforce initiatives. How are you going to start to fund things so that people, say, I could do that. I really wanted to do it, but I just couldn't afford to do it. So 24/7 is hard. Some of the strategies that folks are using around 24/7 is incentivizing being on call for the night shift. And if you go out, you even get more. And that seems to get a whole lot of folks willing to do that. Okay? Because the reality is they don't get a ton of night shift calls. They don't. Between 11 and 7, there just aren't as many for youth. All right, so around policies and planning, you need to think about how this service fits within your 988 system. How does it fit within your local state and system of care? Statewideness is the biggest issue. I would say pilot it first and then, gradually try to get to statewide. There's a big question around use of telehealth. I think telehealth can be quite effective. I also think it's not great at working with like more than one person. So if I'm trying to stabilize a family on a TV screen, get back here, wait, come here, wait. You know, can you take the camera into Johnny's room? You know, it just doesn't work as well, right? So I think you can do some, especially if it's one person getting stabilized. But as soon as you make it a family, you know, you really need to be there. You know, but having said that, Texas is big. And you might need to have some rules and regs around how and when telehealth is not only allowed, but it's an important thing that you do. And then develop a state practice rules. So figure out ways to structure it for all the providers and then ways to pay for it. We put it in our Medicaid plan, our state plan amendment. And Medicaid in Ohio decided they were going to fund it at a rate that made it enticing to folks to want to do it. So is the rate high enough? It's always about the rate for providers to say, I'll do that. Because not only do the folks providing the service not make any money, agencies in general, provider agencies that are doing this work, well, first of all, most of them are not-for-profit, but why should a non-for-profit have to take out a bank loan to pay salaries? Because behavioral health in general is underfunded. And if I am elected, I just had a mental note. You're getting preachy, Rick. You know, pull it back. All right. All right, some other decision points. Who are you going to serve? Everybody? What's everybody mean? Well, first, let's say, is it, you know, birth to 21? We chose birth to 21, so we're serving kids in transition. Any diagnosis? No diagnosis? In New Jersey, I think Maryland, Ohio, you know, we chose to say, whatever it is, diagnosis, no diagnosis, we're coming out. We'll figure out how to fund it later. That's interesting. Medicaid, not Medicaid. Doesn't matter, we're coming out. The back end of that, though, is how sustainable is it to that agency providing that service? Is it any crisis? Are you screening for certain kinds of kiddos? You know, the purest rendition of this service is the family defines the crisis, and whatever that is, you're going out. Right? That's true, you know, system of care. Well, if that's the case, then it's about, okay, we're going out. How do we fund it? And then any system. Can the school call? Can child welfare worker call because they got a kid that's blown out of a placement? What about a kid on probation that's not doing well? Is it just the youth and family? Or can it be systems, right? So we're trying to make ours as big as possible to serve all kids. So that means kids up to age 21. It means kids with co-occurring IDD. It means kids with co-occurring substance use. Kids in the child welfare. Kids that are truant, right? Well, that's a big swath of kids and families. So be thinking about what's doable, how you're going to fund it, because these decisions play into the next slide. Because I designed the PowerPoint, I knew that. And it goes back to the point on the first slide, which is funding this thing needs to be like any other emergency service, like police, law enforcement, like fire departments, like, right? Emergency rooms in healthcare. How do you do that, right? Because we don't like to fund behavioral health necessarily. So is it a combination of state and local? Are there some national funds that we can use, federal funds we can use? You know, Medicaid seems to be the go-to for everything we do. It's a good place to start, right? I think it's a really good place to start because the environment is such that the feds want to fund crisis continuums because they put it out as a major initiative, right? So they're very open to changing state plan amendments to include a more robust crisis set of services for kids and families as well as adults. So it's a good time to move forward with that. Insurance. I wrote it up there because I have to. I don't know that it covers much, but because we don't have parity, we don't, you know. But how do we, you know, advocate for that? And I think more critically, I think you should be thinking about other child serving systems chipping in. If we're helping them, and if our service benefits them, how do we negotiate some sort of a pooled funding or contract with them for their particular kids that they want served? A couple different ways you can go, right? If you don't have child serving systems that play nice in the sandbox, maybe that's more a contract then, saying, okay, you want this? Then here's the cost of that thing for your kids. And you put it all in, you know, with an MOU and all of that. But I would not, you know, rule out, so I know that in some states they have contracts with child welfare, and it's a really nice thing. And they're also contracting with some other child serving systems. The other, well, let's see if I have it up here. No, not yet. So the other thing you want to think about is it's beyond funding. It's about technical assistance and support to serving kids that we're less familiar with, right? So we have a lot of kids now we're serving that are on the spectrum. So we work internally in Ohio with a set of providers that have formed their own coalition that can train our behavioral health staff on everything we need to know about intervening in a crisis with a kid that has co-occurring IDD. All right? So working cross-system is not just about funding, it's about getting that cross-training. Think about the specialized nature of the person having to go out, right? So that's the other thing you should be considering. All right, staffing. You know, these things are staffed differently in every state. I think what you need to think about is what credentials and training. I would strongly encourage you to consider peer support as part of your crisis team. We did that in Ohio, and my God, the families love them the best. They do the stabilization piece, and you know, it's gone over really well, and it's also extended our workforce, right? So think about how will you use peer support as part of your mobile response team. What staffing capacity is needed to provide 24/7? So you got to think about that all ahead of time. And then what role does your licensed staff play? Do you need someone to be able to assess for, to do a suicide assessment? to, to do an assessment around psychiatric acuity about what's needed in that moment, if it needs to be stepped up a notch. Are they the person that goes out on the initial call? That's what we did in Ohio. We're pulling that back now. Why? We can't find licensed people. So there has to be a licensed person that's available now to support the person going out and doing the mobile response, and they need to be available by telehealth 24/7. I mean, and again, you got to adapt in this crazy environment we're in. So this is who we have in Ohio. I'll just leave it up there for you guys. But we do use peer support as a team. There's a licensed person that's kind of overseeing it, and then you could have a parapro go out, an adult peer recovery supporter, even a young adult peer recovery supporter, though we don't have any yet right now. And then you also have to have some sort of psychiatric support available for consultation. That's what we do. All right, one last slide, and then I want to take a few questions. Role of law enforcement. This is a big debate, remains kind of a big debate in Ohio. MRSS typically responds without law enforcement, okay? Unless there's an essential safety reason, and as a last resort, should include the youth and families' input in the decision to use law enforcement, and make sure that the youth and family is aware ahead of time. And when a co-response is necessary, you guys get there first, and you talk to law enforcement before any intervention is made. And you let them know that this is a behavioral health response, they're there for safety, and when the safety thing is established, they can leave. All right. We don't use a ton of law enforcement in Ohio. In pockets, there are folks that do more of it than others. But think about, from a family perspective, who wants flashing lights, police cars in their driveway or on their street in front of their house, and their kids getting taken out and put in the cruiser? Even if it's just for the lecture, you need to respect your parents more. Don't make me come out again, right? I mean, these are the standard things that you hear, right? So, system of care, family perspective. If you had a crisis and you called the call center and wanted somebody to come out, do you want the police coming too? I challenge anybody in the room. And I'm thinking, I don't want the police coming to my house. So you also have to think about that, right? But safety is an issue, so there could be issues where there's domestic violence, there's a gun involved, and you got to think about a safe response to you guys. So there are reasons why, but it should be the exception, not the rule. All right. That's what I know about MRSS. That's what I know about adapting a service that you think is going to work swimmingly well in your community or your state, and you got to make changes. I'll be happy to take any questions that you have.
I have the microphone over here. Is it working?
Yes.
You can hear me? Okay. Who wants to ask the first question? Oh, of course it would be all the way down here. Ariana, can you stand up and just yell it out really loud? I can come to you if necessary. Okay, got it. So we need to wait. I'm coming.
I'm not allowed to jump down, so.
The next question will be right back there, I'm sure.
So you mentioned about staffing shortings and things like that. I was curious around your policies on your staffing because with a lot of peer support comes a lot of maybe criminal justice involvement and things like that. So what are you seeing as far as your staffing shortings?
So are you asking about the additional support that's needed?
I'm asking specifically, like whenever you're looking at staffing issues, are you seeing people having backgrounds that are maybe you're wanting to hire, but you're not able to hire because of the policies already set in the nonprofit areas and things like that?
The way we deal with that by what we put in the state rule. And the state rule is very specific that if you meet these, peer support requirements, you're eligible, and we entice the agency to think about it by the rate that we pay peer support, which is higher than I've ever seen. And so partly it's about incentivizing, and partly it's structuring the rule. But yes, it could be at the local level, at the agency level, there could be concerns. But we try to incentivize it through funding. Other questions?
Another question here.
Yes, from a law enforcement perspective, I feel like we've been asked for years and years and years to resolve behavioral health issues without the background that many people here would have to do that. When y'all implemented this, how did law enforcement respond when you asked them to take a back seat in the situation?
We have found what we have found is that law enforcement, at least in Ohio, says, thank you, because I don't want to do additional paperwork, and I need somebody else, and I got to be somewhere over here, and if I'm stuck here in a behavioral health crisis, if I'm the only one, I'm going to be here a while. And so they like it a ton, and so especially if there's special training for special officers as well, but they love it.
I'm just curious, in Ohio, how do you get around the transportation issues if the law enforcement's not involved? I think it's a great idea not to have all the lights because it's more traumatic and you want to be anonymous and private and not cause more trauma to the families, but you need more staffing people to do the transportations for the kids in a safe manner. How do you get around that?
Are you talking about transportation to a hospital, or are you talking about getting to the family's home?
Yeah, like if you call after hours on a crisis, and our police and in our agency, the police has to be involved to transport the kids in a safe manner. But how do you guys do that in Ohio? So, what I would say to that is, if the child needs to be transported, you would have to follow whatever the local community rules are about, right? Or the agency rules. So we generally don't transport kids to the hospital. We might have the parent, and I'll meet you there. Or it could be the 911 call because you might need the police. If the kid is truly at risk and needs an emergency stabilization that only an emergency room can provide. So, so in that case, we probably wouldn't do that transportation. That's a great question. Thanks for asking that.
Hi, thank you for your presentation. I know you said Ohio recently implemented this like a year and a half ago. So I'm wondering, for the states that have had it for longer, have they seen a reduction in emergency room visits, juvenile justice involvement, things like that?
We are just getting our data in, and I'd love to answer that question. What I can tell you is New Jersey, Connecticut, Oklahoma, Nevada, the answer is definitely yes. Yeah. For the folks that are doing this for more than 5 years and gathering that data, and I can make that available to you guys, if you get on the CHDI, Connecticut,
I don't know what the HDI stands for, but Google them. And but they have reports they put out, and I'll send it to the organizers, and we can get it out to you. But it will talk about the very real effect in the community.
We have time for probably 2 more questions. I see one here, and were there, oh, and Alice, okay. Go ahead.
Hi, I have 2 questions. So a little bit of talking about the data. I know it's new depending on which program, which state is using it, but what has been like the parents' response, feedback that has been using the system? Because in order to improve something and even implement it, the families who's using it, it can be positive and negative. Do anybody have that where that, other agencies can look at it, because it could be they didn't respond, or they wish this could have happened instead of this, and that'll be helpful with implementing for any other state or other agency to kind of see, oh, we should have had this in place instead of this.
We use family feedback surveys on every family that gets served. And then we collate all of that as quality improvement, and it feeds into our fidelity management of each of the programs. So it's a key component, absolutely. And then all the data is compiled so that we know what we got to fix. Because it ain't ever going to be perfect, but you have to make sure that it's good enough, right? And that it's family responsive. No.
No, Alice, can I ask a question? We're friends. So you talked about paying for this the same way we pay for all other emergencies, that would be the dream come true. Are you collecting data? Because we're paying for it with all the other emergencies. Like the gentleman talked about the police. The police are going to be called, emergency is going to be called. So this is getting paid for in other pockets. Is some of that data being collected to advocate and possibly change policy so that it can be paid for here?
That's a great idea, which I'm going to take back.
And then you have to send me something to take me to lunch. Just send me the card. I'll go to lunch because I gave you the great idea.
Well, maybe next year you'll do our keynote.
Ooh, that would be fun. We'll work on that together. It'll be a team.
No, that's great.
We like to laugh. This is good. So yeah, because we're going to pay one way or the other, so we'll collect that data. Here we go. Now I'm saying we.
Critically important. Yeah.
Yeah, collect that data to show we're paying. Just depends on how you want to show it. Or we can start doing more prevention and pay that way. And we all know that's cheaper.
Yeah, and you just have to have the data, And, you can look at hospital diversion. You can look at residential treatment, right? You can look at juvenile justice involvement and the cost of that. The cost of child welfare for kids that are going into child welfare that aren't in child welfare. You can make the argument. You need the data to make it, right? Great point. One last thing. Here's the references. These are all very, very current. If you go on, we have a website in Ohio, MRSS Ohio. And I created a toolkit for MRSS. We also have a practice manual that our state created. Our rules are on the MRSS Ohio. The fidelity tools on MRSS Ohio. We believe in democratizing knowledge, so here you go. Thanks, guys.
Incredible. Thank you, Rick. Rick came all the way from Ohio to do this presentation, and it sounds like you guys really listened and considered what he said. So thank you for being so considerate and thoughtful and paying attention to his presentation. Thank you for coming. Okay. I have a few announcements before we dismiss. Yesterday, I forgot to introduce myself, so you were probably wondering, who in the world is that person? I'm Tammy Holland. I happen to work at the Institute for Excellence in Mental Health over at UT, and I'm involved in the system of care as the services and training lead. So, and I'm on the planning committee for the conference. Okay, so There is a workshop this afternoon that you might be interested in attending, particularly in light of this presentation, and it's the Youth Peer Specialist Panel. Ariana and Paul, could y'all stand up for just a minute? I don't know if there's any other peer specialists in the room. Are there? No? Oh, yes, please stand up. If you're a peer specialist, stand up. Okay, so we're having these folks, some of them, are all of you going to be presenting on the panel? No, not, Matthew sat down. There was no obligation, Matthew. I was just curious. But these two, I believe, are going to be speaking on the Youth Peer Specialist Panel, and that's this afternoon at 1:30. So if you want to hear more about how to utilize peer specialists in the provision of MRSS, please consider going to that workshop. Thank you so much. And Matthew will talk about speaking at the other one. Okay. Let's see here. All right, do you still have your tracking sheet for your workshops? All right, go ahead and put a check mark next to this keynote. Be sure that you put a check mark next to the workshops that you attended yesterday, and keep that worksheet because you're going to need it at the conclusion of the conference. You'll have to go to that QR code to request your CEU certificate or certificate of attendance. You will not receive a certificate if you don't request it, and you're responsible for tracking your own attendance and requesting it. Today's schedule, after this keynote is finished, we will have 3 different series of breakouts this afternoon. So one will immediately follow this session and begins at 10:15. After that breakout, we'll have we'll have a lunch for you. Like real lunch. It's going to be pre-made sandwiches, but it will be on a buffet. So you'll go through the buffet line and easily grab sandwiches that are already prepared for you. Now, if you're a leadership position on a CRCG, we would encourage you to grab your plate lunch and go over to the balconies room by the registration table and join the other leaders of CRCGs for some networking and discussion. And then after the 1:15 breakouts, we will have refreshments for you. And then the last breakouts will be ending at 4:30 today. At 5:30, this gives you a little bit of time to relax, to decompress. You might want to change clothes, I don't know, put your bowling shoes on. But tonight is the Punch Bowl social event. So I have to show off this beautiful poster. Have y'all seen this? We're having a bowling tournament tonight at the Punch Bowl Social. This is really going to be a really fun event. There's 4 bowling lanes. The cost is already paid for. You don't have to pay for a thing. All you have to do is go to Punch Bowl Social either by shuttle bus or car. All the parking in the domain is free, and they have multiple parking garages. So when you go to the event, we will have lots of games, including free bowling. And there's lounge chairs, sofas. It's a real laid-back place, real laid-back. We're not going to be providing dinner at the event, but we are providing heavy hors d'oeuvres. That means like, I don't know, macaroni and cheese and sliders and stuff like that. You may not even be hungry afterwards. But if you are, you can order from the menu, or there's 100 more restaurants in the domain area that you can go for dinner. So back to the bowling. We're looking for people who want to bowl tonight. And good. And I'm looking, Rick, I need a bowling partner. I don't know if you're available later. You don't have to be very good. Okay. Ariana, do you bowl? You don't bowl, okay. Matthew? No, Matthew? You don't bowl? Okay, I really need a bowling partner. So bowling, all you need to do is sign up on this poster sometime before tonight. Just write your name on one of the team spots. No more than 4 people per team. Now, this is how we're going to give away door prizes tomorrow. So the winning bowling team with the highest combined score is going to win door prizes tomorrow. And the person on that team with the highest score will win the most special door prize tomorrow. So if you want to bowl, please sign up. We could do a booby prize for the lowest score. Good idea, Alice. You're full of good ideas today. All right. So if you want to bowl, sign up. If you don't sign up and you get there and there's open lanes and no one's signed up, you can just bowl. You don't have to be in the tournament. But this is going to be fun. And ESPN is not covering the event, so there's no pressure whatsoever. Okay? Okay. Let's see. Does everyone still have your passport, your exhibitor passport? Are you getting it stamped? Awesome. So as soon as you have 20 stamps in it.
It's only 19 exhibitors.
Okay, we have more today.
No, yeah, I did already. I went through all of them. It's only 19.
Is there only 19?
Yeah.
Okay, then ask somebody to do it twice. Is Kayla in the room? Kayla? I thought we were expecting more. Double check, because I know that there were some new exhibitors coming just today. But if 19 is all there is, then get them all filled out. And then take this to the registration table. Don't forget to put your name on the cover. Because tomorrow during the general session, we're going to be pulling some of these out. I think numerous, like 3 or 4 of them. And people will be getting door prizes through that method as well. Let's see. That's the bingo game, the exhibit hall. The photo booth. Have y'all found the photo booth? The photo booth is over by the cafeteria entrance. So there, the iPad should be set up, and you can just help yourself and take all the selfies you want. And there's props to use, so enjoy that. Also, on one of the exhibit tables closest to the registration table, there are free calendars for you guys to take. And these calendars are wonderful. They feature the artwork from the annual mental health arts contest. I'm losing my words. And that arts contest is celebrated during the same month as Children's Mental Health Acceptance Day. So the artwork that's also on display throughout the conference center is the artwork from, I believe, this year's arts contest. So you'll be able to see who all the winners were in all the different categories by reviewing the arts displays around the conference center. But please help yourself to one of those calendars. Take one of them home with you. There's also system of care posters that are being given away for free. Lots of other stuff out there. If you are due money for travel reimbursement, now, don't make this up. Don't make this up, Ceci. But if you really are due money for travel reimbursement, Glenn Dembowski is the holder of the money, and he's located in the Mustang Room. The Mustang Room. That's where you'll go to get your money. There is also a speaker ready room if you are one of our speakers. The speaker ready room is also right next to the registration table in the tower room. The tower room. And that's like a green room for speakers to go and, I don't know, what do y'all do before you speak? You meditate or meditate? Yeah, whatever y'all do, that's what you can do in the speaker ready room. Yeah, I can't say that. Okay, and there's also a wellness room for anybody and everybody who needs a quiet place to get away from the crowd, and that is in the Longhorn room. The Longhorn room. That's the wellness room if you just need to get away from all of it. All right. Also, I wanted to mention that if you go to the conference website or the CRCG website or the System of Care website, all of those sites will take you to the conference registration page. And on that page, if you click on materials, you can get the slide deck of all the workshops, including the keynotes. And it's also right there, there's a link to the evaluations for the sessions. So if you forgot to evaluate, let's say, yesterday's keynote, you can just go there and click on it and complete the evaluation. So remember that all of that is available to you on the website. Slide decks, making sure I got everything. Okay, 2 more things. All right, first of all, let's explain this part, and then we'll give away the door prize. Okay, in this jar are the admission bracelets for tonight's Punch Bowl social event. You cannot get in the door. I mean, you can, but you can't be part of our party unless you have on one of these trendy orange bracelets. So I'm going to ask somebody, Alice, could you come and grab this and take it to the back? And our planning committee members are going to have a handful of these bracelets at the exits of this room. So if you would like to go tonight to Punch Bowl Social, it's 5:30 to 7:30. Come and go, very relaxed, no program, no speakers, just food and games. If you would like to go get a bracelet, you may only have one at this time and you must be registered to go to the event. But if you have a guest, somebody that you'd like to bring with you tonight, a child, a spouse, I don't know, a professor from Ohio, anybody, you just go to the registration table and there's a form there that you can fill out to request extra tickets. Okay, so you have to sign up for extra tickets. At noon, we're going to begin giving away those extra tickets. So as soon as noon gets here, if you signed up for one of them, make your way to the registration table so you can get some bracelets for your children or whoever it is that you want to bring. Okay, Matthew, do you have a date for tonight? No, ma'am. Oh, well, that's a date. Okay, y'all can get an extra bracelet if you need to. Just go to the reg table. All right, those are all of the announcements. We are now going to our first series of breakouts that begin at 10:15. Don't forget to evaluate this conference, this session right here. The QR codes are on the back and on the doors. Please evaluate this session. Thank you, everybody. Have a good day.